Okay, good morning. It's 8:30. We'll start the November Board of Health meeting. For the record, there's a copy of the Open Meetings Act on the north wall of the legislative chambers. And with that, we'll have roll call.
Wade. Here. Festerson. Here. McNally.
Here.
Rogers.
Here.
Weiss. Here. Jones. Wilkin. Here. King. Espinoza.
Item 2 is approval of the minutes from the October 16th, 2024 meeting. Is there a motion to approve? There's a motion. Is there a second? Second. Roll call.
Wilkin.
Abstain.
Wade.
Yes.
Rogers.
Yes.
Weiss.
Yes.
McNally.
Abstain.
Espinoza. Festerson.
Yes.
We'll go to item 3, and that's approval of items A through L. Does anyone need anything removed for any reason? If not, is there a motion to approve the agenda items? There's a motion. Is there a second?
Second.
Second. No questions. Roll call.
Festerson.
Yes.
McNally.
Yes.
Rogers.
Yes.
Wilkin.
Yes.
Espinoza. Weiss.
Yes.
Wade.
Yes.
We'll go now to presentations, and we'll jump right in with item A and the community benefit report from Methodist. And Jeff Prohaska.
And let me share this, just that way you've got it. Okay.
Arrow to advance.
Yes.
Up, down. Thank you. Good morning.
Good morning.
Thank you, Commissioner Rogers. Thank you, Board, for allowing me to come and share an update on Methodist Health System's progress in our community, the goal of improving the health of Douglas County. I want to start by giving you some insights into our strategy. I think it's, it's not advancing when I click the button. I'm going to try this. There we go. I think if you ask anybody at Methodist Health System, what are we focusing on? They're going to give you these 5 key pillars. And I do this to illustrate where commitment to community sits. This is our core strategy. People and culture, our commitment to our community, our quality and safety, our smart growth, and doing that as an integrated system. Those 5 key pillars are everything we focus on from a strategic perspective. And community sits amongst those 5. It's all boosted up by our mission, which is to improve the health of our communities by the way we care, educate, and innovate. Now I'm going to go through some key areas from the Community Health Needs Assessment, and I'm going to show you examples and priorities that Methodist Health System is executing in our community. The first one, access to health care. Now just by our being, as a health system, as a regional health system in our sites of care, we are providing access to patients across our region. We have 4 hospitals and over 45 sites of ambulatory care providing access to patients that need it. But more specifically, we need to be there for them. And in order to do that, we have to be innovative in approaches such as urgent cares. Not everybody can make an appointment and get to the appointment when they need it, where they want it, how they want it. These urgent cares are convenient approaches to providing access to patients who need it. Next is immediate care. We have many sites across the community where we have primary care physicians where you do need to call and schedule an appointment and wait your turn and get in at that point. Right next to them, co-located, are these immediate cares, which are, as the building is open, there is a set of physicians that are ready to see you on a walk-up basis. So we're trying to be available, convenient, and accessible to patients across the region. We know it's confusing. We know the healthcare environment is difficult to navigate. We've created a hotline, 354 CARE, that any patient, any community member can call and find access for the services that they need. And we know from the Community Health Needs Assessment that cost is the 3rd most prevalent burden to access to care. Our financial assistance policies are in place to ensure that that is not the case. You're going to hear the term innovative again. 3 innovative approaches to providing access to care across our community. The first one is we formed a formal partnership with Heal Omaha. It's providers from our emergency department on a volunteer basis that are providing street medicine to patients from our emergency departments that are homeless. They are out there providing care to these patients discharged from the emergency room where they need it. Next is our Methodist Mobile Diabetes Center. It's providing screening and education in the community. We're up to 15,000 patients since 2018 when we started going around the community. And we are at 90+ unique screening sites. In fact, we did add another unit. So you'll see this one's a full RV coach, right? We found it was a little bit difficult to navigate in some alleyways and some parking lots, so we bought a Sprinter van that doesn't require a CDL driver as well. So it maneuvers a lot better and it's a little bit more convenient for us. So we have 2 units operating in the community. We are partnering with the Douglas County Health Department on lead screenings across Douglas County. Our Methodist Community Health Clinic is 23,000 patients that have been served since we opened in 2017. It's located in Kuntz Lutheran Memorial Church. And I think really the nice thing is it's an integrated approach to taking primary care medicine with behavioral health and social work all combined in an integrated approach for a community that really needs it. It's free and reduced fee, and it's located in such a place that we can really leverage that Kuntz Food Pantry as well as the Healing Gift Free Clinic, which is also co-located, and create a community hub for health improvement. Now, last year I suggested that we were beginning a pilot for screening social determinants of health, and I think it was Dr. Jones' question, why are we just doing it there? I took that as a challenge, and I took that back to the team, and I said, you know what? Let's take the things we've learned, the successes and the challenges that we've experienced with that pilot, and let's expand that. And our team responded. We are now on course for a system-wide standard for identifying and addressing social determinants of health. Our goal is to develop a health equity plan for each hospital and every clinic. Our leaders are truly engaged in using the data to identify our priority populations and develop action plans to address them. Now, what we've done, we have effectively rolled out our screening mechanism to all of our hospitals and all of our clinics. Now, that's one thing to screen and identify. Well, yes, you've identified a social determinant of health. What are you going to do about it? So the next step, and what we've also implemented, is an evidence-based assessment tool that it says, okay, you have that social determinant of health. What types of resources do you need to remedy it? We have implemented that, and we have taken the next step to actually make referrals to community resources through a software platform called Community Relay. So that's where we are. Where are we headed? We're developing true health equity solutions. So after we've identified and we've made a referral, we have a whole bunch of information there. We have information about our community, specifically those patients that have come through our doors and been screened and identified as having social determinants of health. We need to analyze that. We need to say, what are our most common problems? What are our challenges? And take that and go out and build partnerships with resources in the community that we can refer to. We can be efficient because of the data and pick the right targeted resources within the community which we really need. We can partner with them, and the real reason we want to partner with them is so that we can build a bidirectional relationship with that data, so that once those patients are seen by the resources, are helped by the resources, we can get feedback. With that feedback, we can now measure outcomes. Now we're there. That's where we really want to get to. If you're measuring outcomes of, we identified challenges, we made remedies, did it work? And that, if it's working, you're executing population health, at least the social determinants of health part. Next one is cancer. So at Methodist Estabrook Cancer Center, we're taking a very focused approach on lowering mortality or increasing survivability of cancer through early identification. Now, this is really focused on screenings and promotion of screenings. Getting the word out, the education out, the knowledge out about when screenings need to take place and where to get them. We're partnering with community members to make this happen. Binational Health Week, Black Family Health and Wellness Association, we're doing a lot of this at Coons Pantry. We're taking our cancer providers down to that Coons Pantry and educating in the community about screenings, actually performing some screenings there. One World and the Prostate Cancer Alliance, many events that they're putting on. One of the easiest ways that we can do to make it easy on our patients or the community to get screened is to take it to them. Our mobile mammography unit, the Pink Coach, is out there in the community providing mammograms. On outreach days, there's no cost to participants. We're partnering with community-based organizations as well as employers across the city. And what we're finding, and this is amazing, is that almost 20% of the people on those outreach days, on the community days, this is the first time they've ever been screened. And it's likely, had we not taken that screening opportunity to them, they wouldn't have been screened, making a real impact there. We're up to 172 events a year, seeing almost 3,000 patients every year. Partnering is very important to us. One World Charles Drew, Completely Kids, Latino Center, All Care Health Center, North Omaha Area Health, and the Intercultural Senior Center, all sites that we take that coach to and offer 3D mammography. Next one is infant health, more specifically birth equity. Now, I had the opportunity, and we do this every 3 years, to do strategic planning. And as Chief Strategy Officer, I lead the process. And at Methodist Women's Hospital, I challenged them. I said, you guys are foremost experts in our community on women's and mother-baby health care. As that role, as foremost experts in that space, you are leaders. And you must be leaders across the board, not just for our patients. And they took that to heart. They've incorporated into their strategic plan a concerted effort to be focused on the community as leaders of women's and mother-baby health care. They've developed partnerships with the Black Maternal Health Coalition. They're partnering with IB Black Girl, working diligently to develop free childbirth education and lactation support groups offered down at IB Black Girls and NARCA Center. They're providing nurse educators to assist with their doula passage program, and a whole holistic view of the relationship that we have with doulas in the community. It's an interesting one because, you know, a hospital versus a doula is very different. The care that OBs provide and the care that doulas provide, they are directed in a separate direction. So to build a team approach, to build a trusted relationship that I trust you and you trust me, and we're all out for the betterment of these patients, and all about that is infant health. And I think that's an interesting approach, and I'm really excited to see where that one heads. The Nebraska Diaper Bank, Methodist Women's Hospital has become a distribution hub for new moms that qualify for these programs and the diapers assistance. Probably most importantly, our nurses and our social workers at Methodist Women's Hospital become advocates for these patients. It's a difficult process to access that assistance. These people help those patients or those new moms navigate the assistance program. More birth equity, our Nebraska Breastfeeding Coalition 1 for 1 campaign. Ultimately, this is about building lactation consultants that are certified and extremely skilled and knowledgeable. We're offering scholarships or helping fund scholarships for the mentoring of these lactation consultants, specifically those of color, also focusing on rural and underserved areas of the state. The Nebraska Perinatal Quality Improvement Collaborative is a citywide and statewide program focused on improving infant health. It's mostly maternal fetal medicine providers and educators and programs that are working together to improve infant health. And I find it interesting, and it's just perfect because it aligns so well with the goals of our community of improving infant health, that birth equity, doula support, perinatal depression screening, maternal substance abuse, and neonatal withdrawal, breastfeeding, and congenital syphilis are all aligned. These are their target areas, and we, as Methodist Women's Hospital, serve a leadership role in that space. So really directed all at the same thing, improving the health of our infants. Mental health. So I always bring the community counseling program because we're very proud of it. Across our community, we are in all Omaha public middle schools, high schools, and alternative programs. This is new. We are now in Metropolitan Community College, and we are in community churches as well, so the community at large can access these services. Last year, we served 1,200 patients, And Commissioner Rogers, you asked what were the top presenting problems in our schools. Anxiety, depression, and behavior problems. And I found that a little bit vague, probably not a direct answer, so I drilled down. I called the head of our counseling program yesterday, and she said PTSD. She said that not necessarily the traditional single event trauma, but a lifelong of trauma was pushing these anxiety issues, pushing these depression issues and behavior problems. And I think what she made a comment on was that the barriers to access to care for that trauma, for that PTSD, the first one was trust. She said that traditional counseling is not a trusted approach by the community. And second was transportation. And she said that the unique ability to be in schools put them in a place-based situation where both of those were eliminated. The schools build the trust, and quite honestly, when the kids access us and their families see what's happening, they probably don't really even know they're seeing a Methodist provider. That's a school-based program. So that trust is eliminated, and the fact that it's in the school, that student's already there. So we've taken those two barriers out of the program, or out of the process, which really assists us in outcomes. You can see our no-show rate because of those two things is 10%. Nationally, it's 20%. So we're half the no-show rate just because of our approach of being co-located with OPS. Community partners, Douglas County Educational Collective Advisory Board, Foster Care Review Board, Suicide Prevention Collaborations, and the OPS Career Pathways Program. We are in Girls Inc. and Boys and Girls Club in the summer. The school year, when the kids are not in the schools, they still have needs. We found two great access points there with Girls Inc. and Boys and Girls Club. And we are building bandwidth. Counselors is a definite need across our community. We're trying to help build bandwidth by being a clinical site for the UNO Master's Program. We are still opening in 2026 our Methodist Jenny Edmondson Behavioral Health Hospital. It's in partnership with Acadia Healthcare. It's a 96-bed behavioral health hospital. The purpose of it is to increase the overall access of behavioral health in Council Bluffs and in Omaha. It's conveniently located so that both communities can access it. At the hospital, it will offer intensive outpatient and partial hospitalization, but in the community, school outreach programs, suicide prevention training, teacher and school counselor training, veteran and military outreach programs, and they do that in close partnership with law enforcement. One of the reasons Acadia does love to come in and partner with the local health system is for opening doors, and we're going to work closely with them to build these programs across our community. Our strategic planning process begins with a survey that I conduct with each of the leaders across our organization, presidents and other executives. The number one issue that we found over the last 3 years was talent, was people, was access to resources that we need to provide care in our community. And we're having to be more and more innovative to fill our staffing needs. And just wanted to give a couple examples of approaches that we're taking. Partnerships with the Immigrant Legal Center and Refugee Empowerment Center. We're finding people to come and be great talent for us. The Upward Bound program at Benson and Burke High Schools. These are underserved kids that we're trying to build an interest in healthcare careers with them. And we're starting early. We're allowing shadowing and internship opportunities as early as middle school. Just getting kids interested in healthcare. We need more people wanting to come into the industry. Okay, the finance slide. This is our total community benefit, our total community impact, which is $109 million. Comes in 3 buckets. The first one is financial assistance, so that's your traditional charity care, $18.2 million. And from the prior reporting period, we saw a pretty, I guess, very noticeable shift out of this bucket and into the next bucket, which is unpaid costs of Medicaid programs, $44.6 million. So this was the first reporting period, whole reporting period after COVID and after Medicaid expansion. So both of those two things occurred in the prior 3 reporting periods before this. So I would say this is probably the most new normal after COVID. So Medicaid expanded, then there was this dramatic drop in utilization of healthcare, and now all of a sudden all the healthcare came back and they all had different payers. And mostly they had a payer now, which was Medicaid. So those that were uninsured before now have some form of coverage, which is Medicaid. So that's where you saw this shift out of the financial assistance into the unpaid cost of Medicaid programs. Now, how the model works essentially is that on a government patient, so someone who's covered by Medicaid, essentially only about 80 to 85% of the costs are covered. So the 20 to 15% is really going into that unpaid cost of Medicaid programs. So that goes into that bucket. Our goal is to reinvest heavily back into the gray bucket, which is our community health improvements, $46.9 million. That is our programs in the community. That is our efforts to improve health. Ultimately, what that is early identification, health equity, and social determinants of health with the goal of keeping people out of the hospital, keeping people well. If we can do that, we can reduce the overall cost burden on the healthcare industry and specifically the government. Our method of doing this, and I think you've seen it through the course of the presentation, is by being the best partner in our community. And that's how Methodist wants to do that, as the best partner in our community. With that, I'll take the opportunity to introduce Steve Jackson. I think a lot of you know Steve. He's running point on being that partner builder. He's out in the community. He's out taking the direction from our population health folks, saying here's where we need resources. Here's who we need to talk to. Steve goes out and builds those relationships. We're well over 240 some partners in the community, and we're here to do exactly that. Recognize that we all want to improve the health of our communities, and we're a critical piece of it. Happy to answer questions for you.
Jeff, thanks for the presentation. Curious about the mammography and those women first time ever mammography. Do you have any data on the outcomes of their testing?
Well, yes. We do identify some that would have definitely been I don't have it with me, but yes, we do keep track of how many new cancers we found. And a lot of them are in early stages, which is great. But you know how quickly that can progress. So it's critical that when we find those, I don't know how to phrase it. It's a good thing we found them, I guess is the best way to say it, because they would have been found undetected.
Thanks.
Good morning.
Good morning.
Thank you for your presentation. Great information. I'm following with Dr. Wilkins' question. What is the process then when you do find that cancer on certain women, especially the under or uninsured?
So there's a couple different processes. We can make referrals to our cancer center, or there's also Hope Medical Outreach. So for the underserved, where you reference that, we plug them into that network.
Very well. And then, I'm sorry, one more question.
Yeah, go ahead.
In regards to workforce development, what kind of programming do you have?
Oh, absolutely. Well, our Nebraska Methodist College is running point on that. We've heard the governor loud and clear that the emphasis on workforce development is necessary. We've felt it. So, from a strategic response, we've been working on it. In addition to those innovative approaches, we just need to increase the overall bandwidth of people getting into the industry and wanting to stay in the industry. Retention's a huge effort. It's a lot easier to keep somebody than it is to go find somebody right now. So we're focusing a lot of it internally to try and make sure that we can reduce turnover and increase keepage.
Thank you.
You're welcome.
Good morning.
Good morning.
First, I want to compliment you. I really see that Methodist has grown in as far as its community outreach and how you tell the story. So thank you.
You're very welcome.
So first question is around your community relay piece. Some of the other health systems have been using Unite Nebraska.
Unite Us.
Or Unite Us. So can you tell us a little bit about community relay?
Parallel paths.
Okay.
Yep.
Is it a different tool?
I don't know the technicalities of it,
Okay.
but yeah, it's parallel path. It's
Okay.
same exact type of process.
Okay, great. Thank you very much. And then, can you tell me a little bit more about what you're doing with Boys and Girls Club? I know you mentioned the mental health piece.
Right.
Who
Boys and
is
Girls
it
Club
that's
is
going in?
a site of service for our community counseling program, specifically in the summers, because our counselors, they're based in the schools during the school year. Well, they have those 3 months that we want to keep them active. We want to
Okay.
keep them engaged in the community. So we've been looking for sites for them over the summer months. That's one of them.
Okay, got it. Thank you very much.
You're welcome.
Joe, okay, follow, this is what I'd be curious for. Your number that you gave, the 109.7 million, I'd be curious to, and not that I need it now, but to see your number and breakdown from 2019.
Oh, compared to?
Yeah, because
We
20
were
would have been COVID, and if this is your,
70 million-ish?
yeah, that would have been the year right after
Yeah,
Medicaid.
yeah.
So, and you probably wouldn't have had it set up, but I'd be curious in seeing that number. And I guess, because to Jeannie's point, I do, I want to say I appreciate how your report and a lot of others have evolved. The main fact too is it's a better balance. The thing that kind of peeves me sometimes is when the community benefit piece is given out, but is reinvested in a program you got in the hospital.
Oh,
and it's
sure,
really not
sure.
out there. So I do like that balance on that. Let me ask you though, so how do you all work the school-based thing out when Drew and One World have school-based health clinics in some of these places?
I
and
think
my
they're in the
understanding is-
I think they're in the elementary schools, which we're
Okay,
not.
that's what it is.
Yeah.
Okay, okay.
Yeah.
So, just curious, not for the answers, but so are you all? Were you all called to do some help when the incident happened in Northwest?
Oh, I don't know specifically, but that would have been something, yes. We do provide crisis support.
Okay.
I don't get the reports of the actual events. We try and keep those kind of private, but
No, I'm just curious.
yeah,
but
yeah.
Okay.
That'd
okay.
be the type of thing we do, yes.
Okay. The other thing too that I'd be curious to flesh out, and I don't know if that's us fleshing that out with you, is the number you had on the PTSD deal. Because I'm interested in how does an epidemiologist flesh that narrative out?
I'd love to take that back. What I gave you is anecdotal, I
Mm-hmm.
understand. I'd love to explore that with our counseling team, because there's something there, and she was passionate about it. I mean, I said, "Are you sure?" And yes. So yeah, let me flesh that out for you.
And I would wonder, how do you put that out there somewhere now? Because like personally, this is the piece I have with that. How do you take that PTSD piece and tie it into, I don't know if it has some effect with COVID, but also how do you use it to, and I'm gonna say honestly, this is my fear, the public health and the juvenile or violence world, how do you create that narrative to put some halt to what I'm thinking is going to be a push to lower the age to try to put 10 and 8-year-olds in detention?
Right.
And if you all have numbers that
Okay.
talk to the fact of particularly, zip code and being able
Sure.
to GIS map, I think that's a bigger population health narrative to talk about
Yeah.
and to try to get a hold of, because the narrative right now is like, you got a problem that's out of hand, but the fact is this may be the canary in the coal mine. And
Yeah.
I'm interested in how that gets fleshed out.
Understand the question entirely.
Okay.
Yeah.
Okay. Other than that, I appreciate the report and how you all have evolved it. That's the thing, at least from the presentations that we've seen so far. Everybody has evolved it and went there to a greater degree.
Well,
So
we're
I look forward
listening.
to it.
I
Okay,
think that more
appreciate
importantly, we're listening to you.
I appreciate that. The only other question, one last one. What is the Douglas County Educational Neglect Advisory Board? I've never heard of that. Or can somebody tell me what, you had it on one of those slides, and I've never heard of that.
Steve, can you help me out? Oh, is that part of the community counseling partnership?
Maybe, I didn't write down the slide, but I don't need an answer now, but. if
Yeah,
somebody-
we'll
'cause I'm
follow up on
curious
that
in-
for you. Douglas County Educational Neglect Advisory Board?
Yeah.
We'll
I'm
follow up on it for
Curious
you.
in reverse engineering that and finding out what that's about.
Yeah.
Okay.
Okay. Pete,
Morning, Jeff.
morning.
Good to see you. Just a couple follow-up questions. I was also interested in the counseling in all the OPS schools. I think that's a tremendous thing to be doing and definitely needed in our community. From a workforce perspective, have you been able to find I presume these are psychiatrists that are having these appointments, and are they literally one per school, or how do you organize it?
So they are not psychiatrists, they're licensed and independent licensed mental health practitioners.
Okay.
It's a master's level trained provider. It is very challenging. It's a tough job and incredible amount of training that's required to get there. So it is a limited resource. Luckily, we have a pretty large base of staff for that we've acquired through the years. We're a good employer, a good place to work. People enjoy the work. So we really we're focused on engagement and retention with those folks. There is some churn, some turnover, and that really hurts when it happens. So we are constantly making everybody aware of who we are and what we do and why we're a good place to work. So it's tough.
And does a provider cover multiple schools, or
Right. The one advantage of being a large employer of that type of role is that you can kind of share the spread. It's not as easily transferable as you would think because of the relationships you've built with the administrators and the students themselves. So yes, you can fill gaps, but only to a certain extent because of those relationships. You know, they take a lot of ownership in those particular schools that are considered their home base.
And then the second question was, as you know, the legislature passed the provider assessment program of work that's still going through the process.
Yep.
And we're all hopeful it's approved by CMS here shortly because it will help shore up hospital finances throughout the state. So my question around that to you is, do you anticipate that if that goes into effect, do you anticipate that having a big impact on your community benefit numbers next year?
So the size of the pie, not so much. The mix of the pie, absolutely. So the reason I say not the size of the pie is because I think what comes out of that unpaid cost of Medicaid, that's going to shrink that. So that large unpaid cost of Medicaid wedge that you saw is going to come down. They're subsidizing essentially that. What we're going to have to do is fill it up with that investment in the community. So taking those dollars and redirecting them into behavioral health, it is birth equity and elder care and workforce development. And we've been directed, if this goes, that's what we're going to have to focus on.
Yep. Thanks.
You bet.
Any other questions? No? All right. Thanks, Jeff. Appreciate
You're very
it.
welcome.
Yep. Our next presenter, Native American Community Partners. Okay.
Sorry.
So I just advance the slides from here.
Let me get this going here. Yep, so you're just going to use this, and let me minimize this for you. There we go. Okay, so just hit the button and it'll hit it.
All right. Well, first and foremost, Yat Edo Hehe, which is good morning and thank you in my language. I am from the Navajo Nation down in the Southwest. So I've been here in Nebraska for about 8 years, going on 9 years. And so, again, my name is Echo Hawk Left Hand. Currently, I serve as the administrator for the Office of Health Disparity within DHHS. But I'm here to create awareness around this initiative here in Omaha called the Native American Community Partnership of the Omaha Metro Area. And so this program started well, it's not really a program, it's really a grassroots initiative and kind of a collective group effort from organizations that are supporting Native American populations in Omaha. So back in 2019, I was working with Omaha Public Schools. I was the Indian Education Director, and stemming out of that work, we needed to collect what our resources were in the community that were supporting Native American families. And so with this group, we had representatives from Legal Aid. We had a group called Bluebird Cultural Initiative, Nebraska Urban Indian Health Coalition. There was also our colleges from Creighton University, the University of Nebraska, Omaha. And so it was really a wide net, and we're still trying to create this wide net because there's a lot of different partners that are continuing to be organized and trying to support this work. But in a sense, NACPOMA is, again, a partnership of Omaha-based organizations supporting Native American communities. And so Native American communities are very diverse here in Omaha. I think when I was with Omaha Public Schools, we identified 150 different tribes that were residing in the area. And when you think about those that are tribal or federally recognized, we only have about 750-ish, give or take 25. That number is always changing because federal recognition is something that's an issue at the federal level. But it goes into the thousands if you think about our relatives to the south and to the north. And so to have that big of a number represented in Omaha is pretty significant because none of their languages are similar, none of their ways of being are similar. So there's no one way to address and impact Native Americans in Omaha. And so the mission of the group back in 2019, and we had worked with a consultant by the name of Kim Roth Howe. And she's a great top facilitator. I know a lot of people know her, but she helped us to come to this mission about over the next few years, how might we strategically weave and our respective programs and services to assist our Native American community. And largely at that time, there was a lot of work needed to just create visibility and then also to represent ourselves and different conversations, especially, this month is Native American Heritage Month, seemed to be the only time that people were aware of Native Americans. Other times there was a tokenized approach, but we really wanted to try to provide some authentic feedback and visibility in the community and saying, there's no, I guess the way to put it is just like a pan-Indian way of being. That each tribe deserves their own voice, their own uniqueness, and things of that nature. And so that was what we were trying to provide from 2019. So a lot of those social community connections. However, this past year we had really expressed a need to recenter ourselves and really identify what our priorities are. Because since the pandemic, I think it was just really trying to provide services and food, clothing and housing, and really trying to provide those kinds of resources to the community. But here, 2 months ago, we came together with a few of our members, and using top consensus facilitation again, we identified these 5 priorities of increasing and strengthening internal ties, meaning how do we come together as a Native American community more appropriately in Omaha? Where do we congregate? How do we work together? There was a lot of different organizations that are kind of springing up to help support Native communities, but how do we work collectively and try not to be so siloed or even territorial at sometimes? And so also, how do we recognize and celebrate our excellence? And so this is trying to take a more positive approach, and rather than looking at our disparities and things that we need to do, what are the things that we can be prideful of, and how do we celebrate those? For example, there's no Native American awards that exist in any part of the state. So how do we recognize achievements? How do we recognize, things that have been done? So that was kind of something that we wanted to bring into the priorities of this group. And then our youth is very important. How do we educate and uplift our youth using cultural values, cultural ties, cultural teachings? And this is really working with OPS and then also surrounding school districts. And so the third one is asserting self-determination. And so that's really around tribal sovereignty. And tribal sovereignty is hard issue to address off of tribal reservations because tribal sovereignty, sometimes that's the line, is that if you're on your reservation, the tribal sovereignty is there. When you come into the urban area, it's a little bit more difficult to assert because we don't have any tribal jurisdiction in the urban area. But how can we do that appropriately within this group? And then the last one is cultural advocacy and community awareness. How do we work with community-based organizations to let them know how to work with Native Americans? Just yesterday, I was at a meeting and someone used the term, there's too many chiefs and not enough Indians. And I got the term, but it's also a very inappropriate term to just be using and letting people know about some of those cultural kind of humility types of things to be aware of. And these are all in draft because again, this is just 2 months ago when we're trying to reassemble our team or our group. And so right now we're in the process of prioritizing these 5 and how do we create objectives to create indicators to say that we may have movement in each of these areas. At the time, we had the strengths of the groups, is that we're ability to educate and advocate clearly and have clarity and purpose. We are a multidisciplinary team and group. We each have passion and commitment because there's no organizations that's supporting this. We don't have any funding. We kind of just participate in this group on the side of what we're trying to do in our day-to-day jobs. For example, myself, I'm the administrator for the office, but I participate in this group in trying to move some of their initiatives along. And we also try to blend some of our funding streams along if there's different initiatives that could, specifically support this group. So that, again, is funding sources. We do have some data. We have worked with Andy over here, so I appreciate him for not allowing us, but pointing us to the direction to create some awareness for our group. We have lived experiences. We have all kinds of different people who are participating in this group who have lived in the urban area, who've lived on our different reservations across the United States, who have lived on both. And so we all have unique experiences, and how do we tie that together is kind of the goals of our group. We all have a variety of cultural understanding. Some of that might be similar, but we are each able to explain a little bit about some of our cultural heritage and ways of being. And I think that this group is very creative in how we try to put things together. And we have expertise of different positions and fields. And then youth involvement. We each have a lens or a layer that we can engage our youth. Some of the weaknesses from this group is that sometimes there's a little buy-in from our respective employers. So this is something that is not directly supported by employers. So trying to make time to meet and visit is sometimes an issue because in the evenings, people have their families and other priorities to take care of. And so we try to meet in the middle of the day. Actually, there's a meeting right after this, kind of with this group. And so the other thing is consistency, trying to meet as a grassroots group. Sometimes with that little support or buy-in from employers, it creates, challenges in meeting. And this white supremacy characteristics, it's really just historical trauma and some of those institutionalized practices that have been instilled, in the culture throughout the years. And a lot of that is just around historical trauma and how that's impacted Native American communities. And then again, another one of the weaknesses is capacity, because we don't have the personnel or funding to run this group. At times, we're kind of sharing leadership and saying that this month, can you help me do this and help me lead the group and things of that nature. Accountability, structure, and I think that's the purpose for this recentering ourselves, is to create more accountability and structure. Is how do we ensure that those priorities that we have someone or a team that is going to be helping to address them, and then helping to provide more structure. And then again, that lends to silos, limited collaborative community express partnerships, and then just the intergenerational trauma, especially around the culture of silence. I think Native Americans have been told for so many years, to be quiet. There was boarding schools that eliminated our language. And so there's this culture of don't say anything, don't disrupt the institution, don't disrupt the process, just try to make do with what you have, kind of thing. And so that's something that we are directly trying to disrupt and change. So some of the possible outcomes of our NACPOMA group is improved quality of life for our Native American communities and health outcomes, improved services around social determinants, as the presenter before me had been presenting about. Connection and belonging. I think that's really something that's important for Native American communities. Right now, I think we have 2 powwows that exist in Omaha. There's one at the Fort Omaha, and then there's one at UNO. But outside of that, there's really no other place for Native American groups to come together. But there's a lot around collection and belonging, even social connectedness. There was an article that I read here a few years ago about the 2 biggest social determinants of health impacts. Is one, education or economic stability, and the other is social connectedness. And so the importance of being able to come together and to share your ideals and cultural values is really important. And so that lends into having a collective Native voice, healing and dreaming. That's a part of decolonization, which is how do Native Americans see themselves in Omaha, and how are we able to practice who we are in the city, if that makes sense. And then how do we make more efficient use of the resources that we have to us, and then have a unified community pride and job, and then increase capital, social, economic, cultural, and political status. So those are some of the outcomes that we had discussed from our planning group, and possible dangers to keep in mind of. I think in culture, you see a lot of Native American, I don't want to say arts and crafts, but just different things. I think looking at the designs that Native people make, sometimes they're made by like big companies, and they say that this is Native American influence and things like that, but they're really, just taking from Native Americans and making money for themselves. So how do we prevent kind of a monetizing culture from the inclusion of our community? The backlash from historical trauma, so as we begin to try to advocate for ourselves, sometimes these historical trauma impacts say, hey, you guys are supposed to be quiet and just accept what you've been given in the past. And then also just thinking about casinos and some of these things that other tribes might have the privilege of getting money from, is that, sometimes there's this misnomer that Native Americans are given money and given certain supports that other people aren't, but that's not true. And so some of this backlash is that it's like, you guys are already getting all of this money and all of these different supports. Why should we, try to provide more? Lateral violence within the groups. Sometimes there's again, that's back to that historical trauma. It's just that there's lateral violence even within the group. Sometimes Native Americans, we don't get along, we don't play along together, but how do we get beyond that to try to support, what we're trying to do? And then sometimes those of us that are in this work, we overpromise and we say that we're going to do this, that, and the other, and we kind of overcommit ourselves sometimes. And so these are some of the things that we wanted to keep in mind as we were doing this work together from NACPOMA. And so these were commitments from the group, was that we committed to show up, attend meetings. I'm not going to read the whole thing, but we have commitment from this group to try to move this work along, and also to try to expand the group from organizations or from places that we're not. We don't know where Native American support might be within the city of Omaha. And so with that, unity is strength. When there's teamwork and collaboration, wonderful things can be achieved. So that's all related to collective impact. And I'll leave it open for questions. Oh, we also have a couple people who are joining us on Zoom. I don't know if there's anything that they want to say as well. I think that's Grace.
Any questions of the dais? Go ahead.
Hi. No, I would just like to say thank you for having us here. My name is Grace Johnson. I'm an enrolled member of the Ogallala Lakota Sioux tribe. I've lived in Omaha for almost 30 years. Grew up in South Dakota, and I've been a part of NACPOMA, I think, close to the beginning of it. I do work for Nebraska Attorney General's office as their MMIP liaison, which stands for it stands for Missing and Murdered Indigenous Persons Travel Liaison.
Thank you. Anybody else? Okay.
Thank you, Ekahak. That was great information. It was very eye-opening for me. A lot of the information that you presented, like you've mentioned, we have certain understandings or teachings that we previously had, and so we make our own ideas in regards to your community. But thank you for coming and presenting. A few questions. How often are you guys meeting as a group? Where are your meetings held at? And is there an opportunity for some of us to come and present to your group in regards to different resources that we have in our institutions or where we work?
Most definitely. I think we'd love to have that. We meet regularly, at least once a month via Zoom. I think it's the Wednesday. Today's the Wednesday. Whatever Wednesday that it is this week is when we try to meet. And so I think we're trying to mix in some in-person visits because there's just a different energy when you come and meet in person. And so, yeah, we'd love
Yeah,
to have.
We normally meet on the last Wednesday of the month, but since Thanksgiving and the holidays, we moved it up a week. So our after this meeting is when we're having our NACPOMA meeting on Zoom.
Great. And if you don't mind sending me that information, I would be really interested in presenting in regards to workforce development with CHI Health.
All righty.
Thank you for coming. So I had a couple questions. So I saw within your commitment slide that you had a one about presenting to Board of Health. So you've got one done. But I also noted that you had a health equity committee representation. Is there somebody in particular that you have in mind, or what does that look like to you?
Well, that is, I think, from my office, as the Office of Health Disparity, formerly known as the Office of Health Disparity and Health Equity. And so from my office, we have a person who's a Native American liaison who's helping to support from my office directly into this group. So that's kind of the equity connection.
Okay, great. Because we also have our health equity committee here locally within Douglas County. So if there's somebody that you are interested in potentially participating, please let us know.
Oh, yeah, I'd love to. So I'm letting you know. Yes.
Fantastic. So you'll just to make sure we get your contact information.
Alrighty.
And then do you get, and I appreciate the awareness that these conversations are occurring. And do you have a website? How do you communicate and help recruit for participation, kind of to Celine's point, et cetera?
At this point, we have a Google site that just showcases some of the minutes that we have. Again, we're working towards, being able to present ourselves to the community. But there's also a lot of different organizations. And so not only is Bluebird Cultural Initiative, they have their own website. Healing Ribbons has their own website. And so these groups is, rather than stepping on their toes, is like, how do we work together versus against one another?
Great. Thank you very much.
Echo Hawk, has the group identified any particular ask of local health departments or boards of health as to how we might be able to help your organization?
I think right now we're having those conversations. The meeting right after this is going to be directed towards that. So looking at those five priorities, which one or two do we want to move forward with? And then what is our resources and what do we need to make happen from that? So we'll be asking for sure.
Thanks.
So I missed you earlier. Are you a state organization?
No, this is not even nonprofit. There's no status to this group. It's just a partnership that is organized here in Omaha.
Okay. All right.
Yeah, we initially have been here since before 2019. When Echo Hawk used to work for the Omaha Public School System is when we held a lot of these community or these group meetings. So it's not like we've been here for a while, actually.
Mm-hmm.
You formally informal?
Informally, yeah.
Okay.
So part of the Omaha Public School Indian Education Program is that there was supposed to be a meeting of community-based organizations. So this is within the funding so it's a Title VI funding that comes from the Office of Education. So that was one of the things that we needed to do. We just kind of expanded it a little bit more. Sorry, Andy.
Well, Andy, if you're gonna talk, you need to come up here and be on record.
There's a lot of great work that happens in the community through the North Omaha Community Care Council and the South Omaha Community Care Council. NACPOMA functions in a similar sort of way of being, this is the opportunity for all the different organizations that focus on a particular community, a particular population, to then come together and figure out how they collaborate well together. And so that's sort of the lens to think of NACPOMA. In the same way you think of NOCCC, SOCCC, SOC, representing the interests of North Omaha and South Omaha. Here's a group that really is that collaborative opportunity for the Native community.
Okay, that makes sense. All right,
All righty.
appreciate it.
All right, thanks.
All right, item C, health resource vending machines.
Yep, that's the part I always forget. Okay. Got it. Good morning.
Good morning.
There we go. All right, so I just wanted to give you all a quick update of our vending machines that we're going to be having. They're actually getting delivered at 10 a.m. to the health department, so I am going to be rushing out of here so that I can actually see them getting delivered. So these, as I mentioned previously, I think in maybe 2 months ago, I want to say, but this vending machine, here's the final look of it, and it will provide free healthcare products at 5 different locations and all the items you see here, which will go into more detail. But I just wanted you to see sort of the imagery that we will have going out regarding them. So locations will be Douglas County Health Department, Sienna Francis, Charles Washington Library, Nebraska Urban Indian Health Coalition, and American Dream. So you can kind of see where they're all located throughout the map. We are pretty circling the east central part of Douglas County. So I'm very excited. We tried to really space them out so that they could be in areas where we think folks would really need them based on data that we've seen. So now, what's inside? So this is an actual look of what the inside of the kiosk will look like. There will be testing kits for COVID and STI. I am working on getting HIV test kits. They had to change the packaging through OraQuick so that they would actually be dispensed in the vending machine, but those will probably be coming in the next month or so, I'm hoping. Sexual reproductive health products, tampons, pads, pregnancy tests, emergency contraceptive, and condoms and lube will be available. For harm reduction, we'll have wound care kits, med destruction bags, and fentanyl test strips. And then hopefully another item that will be coming soon, I am just working on potential funding streams for this, is naloxone. So this is actually when you go up to the kiosk, what it will look like. So I'm gonna go back just so, well, I'll show you in a moment. But there is like an iPad screen on the kiosk. The first test and go that you see will actually be the initial screen, so you'll touch it. This will be in 6 different languages. So we found the top 5 languages within Douglas County, and so you can actually pick which language you will see all of these screens in. As you see up at the top, if you're in a life-threatening situation, please call 911. So once you go through, you can select which item you will want to dispense. It will give kind of a picture. We did generic pictures of the items just so we could potentially change them out if need be. So, for example, the COVID test kits, those change based on what the state is able to provide to us. So we left it as generic, but we'll give an explanation of what the COVID test kit is. And then we will also add on, once you click on which item, you'll check out, and then a questionnaire will pop up following that, asking some anonymous questions. We are not collecting any identifiable information. For one caveat, even this one is minor, is the STI test kits, because we will need to do some potential follow-up on those individuals. It is a lab test, so that is the main reason for collecting just one more additional piece of information. But otherwise, everything in here is completely anonymous. We are really just looking for, and I'll get back to it. This is the information we're looking for: zip code, age range, race, ethnicity, Hispanic, and gender identity. So those are really the items that we're asking for, all very generic, not identifiable, because we don't want anyone to feel like this is some sort of tracking mechanism or anything along those lines. We are simply just wanting to know who is utilizing our services. So for the STI test kits that I mentioned, there will be an additional pop-up that just says the product you're dispensing requires lab results. So explains how to return a test kit sample to the kiosk, because there will be a drop box on the side for that. And then, once again, additional items that will be within the kiosk. We do ask a couple additional questions in regards to just who's utilizing our services. So with the fentanyl test strips, some of the questions we're going to be asking are, what is the main reason you're requesting it? Have you witnessed an overdose? Have you personally overdosed? And is this the first time you've received these? For the COVID test kits, simply asking if they're experiencing any symptoms and what's the reason for obtaining tests. So once again, no identifiable information within these. So big question I know that folks will have is funding resources. So the Sherwood Foundation is supplying the actual vending machines and the pregnancy tests. Our CDC federal grant Overdose Data to Action is providing the wound care kits and the fentanyl test strips. I want to give a huge shout out to partners that have helped us provide this a lot of the products within here. Access Period is providing all the pads and tampons. Region 6 is providing the med destruction bag. Women's Fund of Omaha for providing the condoms and lube. Our DHHS Emergency Preparedness Group for providing the COVID test kits. And then with the emergency contraception, those are actually coming from the manufacturer, and those have been absolutely free. So a lot of the items that we're getting are provided to us for free, so we are providing them for free to the community. We are just simply a pass-through to have those available. As I mentioned, we have HIV test kits that we're requesting, which will most likely either come through our HIV prevention program at the state or Ryan White program. And then I had put in a grant for naloxone to our Region 6 opioid settlement funds. So here is kind of what the initial image looked like when we were finalizing them. I personally think they are beautiful. Shout out to our graphics person, Connie. She did a wonderful job putting these together. And then here is what they actually look like in person. So they are getting delivered here shortly, and I am so excited for them. So, what questions do you guys have?
Curious, how does one logistically monitor the supplies in the kiosks and when they need to be?
Yeah, great question. So the great thing about this is this company, we have like a dashboard that will be created once items start getting distributed within the machines, and they will monitor. We know if, going back to it, and here it's hard to see in the picture, but we have a count of how many items are within each of those blocks in the machine. It will monitor how many's dispensed, and then the company, LTS, Test and Go Vending, actually has a courier here in town that will go and fill them when needed.
And how would you describe cost? I mean, it's probably difficult to give a general sense of that across these various products, but how is that done?
Well, so the cost of everything that we're supplying to the community is free. Everything in here will be free for the community.
Okay.
Now, cost on us, the biggest thing that the cost that I'm kind of taking is the actual vending machine, and we lease those. And it is, to me, it seemed like the equivalent, it's a 24/7 access machine within these 5 locations. It is roughly $120,000 for 5 machines to be filled, taken care of, all of that a year.
Okay, all products are free.
Yes.
All right, thank you.
When do you foresee these machines being placed in the community, and how will you communicate to the community that they're ready? That they're available?
Today and tomorrow is when they're getting placed.
Wow.
Yes.
Okay.
That's why I wanted to make sure and present to you all today.
Yeah.
And I am hoping to do sort of like a ribbon cutting press conference.
Wonderful.
We're doing like a soft launch, but then hopefully first or second week of December is my ideal date. I would like to give some education to the community partners, to folks that work there, just so that they're well aware of everything that's in there. They feel well educated to be able to talk about these machines. So we'll be doing that in the next week or two. And then, like I said, we'll be doing a ribbon cutting press conference probably the first or second week of December.
Wonderful. Thank you. Great service. Thank you.
Is there opportunity in the future if a organization wanted to host one of these machines? What's that process look like? Is there opportunity for growth?
I would love for that. So currently we have the 5 machines. That is really what I worked with into the quote with the vending company. I think there is definitely potential to add on to it, just depending on funding. The sites are, I mean, they're big machines because they're outdoor. They're hard to tip over. They've got kind of their own little generator in them, so if they're unplugged, they can function on their own. But I am all ears to figure out how we can create sustainability with this and also add to it.
And then if there are, my brain is going to, like, injury prevention, obviously, I bring a child lens, like distributing, let's say, gun locks or things of that sort. Is there room within these machines to add other products if needed?
That's the great piece, is that we're starting with this, but they can be totally customized based on the location. So if we see that, you know, access period products are needed more at the Sienna Francis House location, we can increase those there and then maybe decrease in another area that they're not utilized as much. So these are all very flexible. We're just starting with this to kind of see what takes at each location, and we can track all of that. I foresee even in the future, I want these to be vending machines for the entire department, all programs, just because I think there's opportunity to get other items out to community members. If it's even like emergency blankets during the winter, if we can provide some of these items and have them available, I want them to be utilized.
Great. Thank you very much for doing this. I'm very excited to see where this lands.
Yeah.
So, Leah, what's the process for determining what goes in and who gives approval?
You mean, like,
Who gives approval on what goes in the machine?
well, I guess right now, we have to test whether or not they can dispense out of the machine.
No,
But
I mean,
if-
you all need to give some thought to that, because that's going to be asked to me at some point. And so, like right now, I can hear some questions. So something needs to be put down about who makes that approval, how it's determined. So when somebody asks me, I got a question. Because right now, if it's just you or the director, then I'm gonna have a question.
Okay.
So somebody give me something to work through. Okay. All righty. Thank you. Very good. And I'm not, to be clear, I'm not, this is anticipation of the environment.
Yeah.
So, all right. Go to item 5, Health Director's Report.
Good morning, and I will try to talk fast today. Okay, so for the health department in October, November, we've been pretty busy. The construction on our improved conference room is well underway, so that should be done hopefully on time, and very much looking forward to inviting you all in to see kind of this great new collaborative space where hopefully we are able to not only be more effective in how we meet together in the department, but also inviting partners in and really being able to facilitate more collaboration and connection across our community. So more to come on that, but things are going pretty smoothly and looking pretty good so far. Last week, we held a FEMR strategic planning session with the national FEMR team. We had them come in since we are kind of relaunching our FEMR efforts. They actually worked for a day with our team to really plan out what this is going to look like going forth, and also had our first community review team or case review team for FEMR, kind of our kickoff with that team last Thursday, and that was very well received. It was a very successful launch, if you will, and so we're very excited to really just see that work gel and go forward over time and really see some great outcomes from that. I believe you saw some data in the Methodist presentation regarding the newer community health assessment data that was really just newly released, and we are still working as a regional health council to determine how that full launch into the community is going to be happening. But I wanted to also let you know that we are taking that data from the regional community health assessment. We're adding some Douglas County specific data and doing a really deep dive into that to see where we really have disparities and gaps in our community. And the hope is that we will be able to utilize that, alongside strategic planning and really our prioritization process going forward for really how we operate and what we do in the health department. And the plan in terms of you getting all of this information, I do have on a future agenda for you to receive that information for the regional community health assessment. And then probably the month after that, you'll be getting really the more in-depth Douglas County specific data. We are very happy to announce that we received a public health preparedness grant that was applied for almost a year ago. And this really provides the opportunity for reimbursement of preparedness or response activities between about $50,000 up to $5 million, depending on what's happening with that emergency. So we would have to front the funds, obviously, as we're going through a response, and then we would be able to apply into this pool of funding to get reimbursement for those activities. So huge shout out to our preparedness people, to Justin Frederick and to Caleb Cudis for getting that grant going and making sure that we have a way to sustainably respond to emergencies. I also want to announce that we have a new STI program supervisor, so we're very excited. She has a military public health background, which I am very familiar with, so I personally am pretty excited to see her coming on, and I think she's going to do fantastic work. She just started last week, and so she's still getting her feet wet, and we will invite her in to meet you in not too long. If you have been listening to the news in the last 24 hours, you probably saw a report about rats, and I wanted to make sure to just brief you quickly on this. They're in the area of 39th and D Street, seem to be an issue with rats in the area. The neighborhood actually has a sewer line that goes right through the middle of it. There is a recycling company that is there, mostly paper products. There's homes and there's an apartment complex, and we've had an increase in complaints about rats in that area. Our team has gone out since we first received those complaints, and we have been working closely with that recycling company and also with that apartment complex, which is really the two places that we're hearing the most from. And both have great mitigation plans in process. I think that my sanitation people are actually out there right now taking a look at some things, just making sure, to my knowledge, we don't see anything surface level in terms of new burrows from rats that we would need to take care of from the public health side. We are working closely with the city to have the sewers treated. Really, this is kind of the outcome of a perfect storm. So it's fall, so you already have rodents who are trying to find places to nest for the winter. We also had heavy rains, which caused some sewer flooding, which of course forces the rodents out into the streets instead of in the sewer. And so there's just more for people to see. But I wanted to assure you that we have had our people out on the ground working with this situation since we first got our complaints. We were working closely with Ron Hugg, who's city councilman in that area. And so we are confident that the issue is going to be resolved favorably. It's just in the news right now. So we wanted you to be aware of that. So we will continue to monitor that, and we will not pull back from that effort until we are sure that that issue is taken care of. I also wanted to give you just a very, very fast briefing on some communicable disease issues happening in our community. We are in the middle of quite a pertussis outbreak. We have had 75 positive cases so far. Most of these cases have really been in the last few months, and we have had over 6,000 exposures. Most of the exposures that we are seeing are happening in schools. And so we have sent out many, many, many letters to our school systems, letting them know about various exposures that are happening. Our EPI team continues to very, very closely monitor that and to respond to each and every case that comes up. We have also sent out a couple of HANs to our providers in the area, reminding them that post-exposure prophylaxis is really important for those contacts so that they don't get sick and then pass it on to more people. And also, we have had a couple of press releases that have gone out. We've done some interviews with the media. So we're continuing to keep this issue in front of the community, really. But wanted to let you know that we are aware and working that and just give you an update on the status of that. One other update, so internationally, we know there's a pretty significant Marburg outbreak that's happening in Rwanda. We've been watching that very closely. So far, no issues here. We have had some travelers come back that have needed just a little bit of extra monitoring, but so far, no concerns. So we are continuing to see that, and it seems like I think things are maybe slowing down a little bit in that arena. So hopefully that continues to happen. With that, I feel like that was maybe the fastest update I've ever done. Just a very quick word on V2R. So this is our last, kind of our last big feature month, if you will, to talk about the values that we have decided to prioritize. And our last one, which I think is really fitting because I feel like it really encompasses everything that we've talked about previously, and that is integrity. We've had some great conversations with our leadership teams and with our staff around what does it mean to have integrity and to do public health with integrity. And I'm really pleased just to hear our organization's thoughts around what that means. And I'm hearing a lot of comments like, we do what we say we're going to do. We do what's necessary for the people who need us. We are listening to community voice and making sure that when we're responding to those voices and with those voices in mind. And so I'm just really thrilled to hear the thoughts that our organization is having around that. And I want to also just point out that these are not like new fancy goals or new fancy values that we're trying to reach. These are all things we are already doing, but we really want to emphasize these as our foundation for our organization. And so they're doing a beautiful job. I feel like we're doing a beautiful job with that. Of course, lots of more conversations to come. And I'm sure you all have started hearing about strategic planning. Hopefully you're able to attend some of those sessions so that we can have your voice and your ideas and your thoughts around how we function incorporated into this new strategic plan. And hopefully in the new year, I'll be able to outline for you kind of an integrated approach to how we're reporting to you on all of the different things that we use to measure how we're doing. So with that, I will take any questions you have, knowing that we have not much time.
Questions, you're good?
Awesome. All right. Thank you so much.
Okay, thank you. Item 6, any report questions from the board? Okay, with that, next scheduled meeting is scheduled for December 18th. And is there a need for?
Yes.
Okay, go ahead.
Yes. So as Dr. Hughes had shared, there's been a change as far as what I had communicated earlier this week. Friday's December 6th administrative committee meeting will be focused on strategic planning, and we are moving that prioritization conversation around education policy to January. We may likely also do that policy conversation also for mental health. That second focus area for our project with Change Labs focused on pediatric mental health. So our goal is that we're going to bring policy options for those two topic areas to the administrative building in January, or I'm sorry, administrative committee meeting in January, and then we provide some feedback as we set some priorities in those two topic areas. One of our question though for January is we typically meet the first Friday, which falls on January 3rd. Since it's so close to the new year, we're unsure with travel schedules if the board would prefer to push that to the following week, January 12th. Or whatever that, 10th, sorry, apologies, the 10th.
Taking silence as consensus, so that would work.
Okay, so we will bump to the 10th, and it will cover mental health and education policy priorities.
Okay. Anything else? Chief? Alrighty, I know of no need for executive session. With that, is there a motion to adjourn? There's a motion, second. Roll call. All right, take the class. All right. Let's see.
Okay. So Wade? McNally? Festerson? Jones? Rogers? Espinoza? Wilkin? Weiss? Okay.